The next injury that we'll talk about, and in this case, can affect a couple of different of the processes, is a tension pneumothorax. Now, a pneumothorax in and of itself doesn't always start out as a tension. In fact, most of them don't. And that's what we call a simple pneumothorax because it hasn't produced any kind of shock-like signs or symptoms in the patient. Simply what it is that there is air now free-flowing inside the thorax where it doesn't belong. Somehow, air gets in between the visceral and the parietal layer of the pleura and just sits there. Now, there's two ways that usually happens. One, if we're talking about penetration trauma, person gets stabbed, person gets shot. Now you've got free-flowing air that's coming from the outside of the body into the body, and it moves through there very easily and gets into that layer between the two pleura. If it's a blunt type of injury, sometimes what happens is that you'll get a portion of the lung that actually ruptures if that energy is strong enough. So when the lung ruptures, now that air is leaving the lung, but the outside of the chest and the skin and the rib cage is all intact. So the air still leaks out of the lung, and now it just collects around that space between the visceral and the parietal pleura. Both mechanisms could never expand to the point of turning into a tension. You can have people that have shotgun wounds, stab wounds to the chest that never develop a tension pneumothorax. But if they have, in particular, a sucking chest wound where the edges of that entry point are very, very ragged, what tends to happen is air gets in, but then those irregular skin flaps tend to fold on each other as that person takes a breath out, and it traps the air. They close together and it traps the air inside that chest. The more and more breaths they take, the more and more air starts to get trapped. And eventually what starts to happen is when it gets to a certain amount of air that's in that pleural space, it starts to basically compress down on that lung on that particular side. Pain gets intense, patient gets a little bit more anxious, so they start breathing a little bit faster and a little more shallow. Add those two things together, that just accelerates that air process of getting into the chest. And eventually what starts to happen is that when you get enough air in there, that air starts to expand because you've got a nice warm chest, and now that that air is in the wrong place, it can expand very, very quickly throughout the whole entire thorax. So as it does that and it starts compressing that lung down, now we have not only a ventilation problem, but we also have a respiration problem. And if you remember the difference between the two, ventilation is that air movement in and out of the system. Respiration is the exchange of gas across a membrane. So when that lung gets compressed, it's actually compressing also down on the lower airways. It starts compressing the alveoli, and it starts compressing the pulmonary blood vessels. All that compression eventually leads to very little, if no, blood flow going through that lung. And on top of that, there's no air that's really able to move in and out of that lung effectively. So add those two things together, and now that person's ability to oxygenate decreases pretty fast. How do you know this is developed? Okay. Well, what you'll start to see and what distinguishes a pneumothorax, a simple pneumothorax, from a tension pneumothorax is that now that patient starts exhibiting signs and symptoms of shock. Because what happens is that, like I said, you have the ventilation problem and the respiration problem occurring. But as that air starts to get more and more plentiful in the chest and that lung gets smaller and smaller, eventually that air pressure starts to push on the heart as well. And what it will do is that, as I say, the tension pneumothorax is in the left chest. That air will start to push that heart towards the right side of the thorax as it starts to expand. It's almost like a balloon blowing up inside of that left side of the chest. And when the heart shifts, right, it's attached obviously to the superior and inferior vena cava. What'll happen is that that heart will literally pinch up against those two blood vessels, and given enough pressure, the heart will actually cut off blood flow draining from the superior and inferior vena cava. That's bad enough, but now to make it worse, what will happen is that if this still continues, Now that air can literally push the heart over into the complete opposite chamber. So even though the right lung in this case would be intact, now the heart is going to take up a lot of the space where that lung should have or should be, and now that right lung can't expand very well, and their hypoxia gets worse. Obviously, their respiratory ability decreases significantly, but now we also have a perfusion problem. So in this case, it actually affects all three processes. How it affects perfusion is that now there's no blood flow able to get into the heart because the vena cava have been pinched. If the blood flow can't get into the heart, obviously it can't go to the lungs, but the lungs are already compressed, so that's no good. And even if they could get through there, there's no blood coming back to the left side of the heart, so it's not going out to the body. And whatever blood is going to the body from the left side of the heart in this whole series of events eventually gets less and less oxygen because the lungs aren't able to supply the respiratory effort to bring the oxygen in. Eventually, because of all that, now that patient's perfusion starts to decrease, their mental status starts to change, and all kinds of things that we see with shock as far as blood pressure and so on and so forth get worse and worse. One of the telltale signs of attention pneumothorax in this case, because of that heart that gets shifted over and pinching off that superior vena cava in this case, is that you start to have the blood actually shoved backwards through the venous system. And now the neck veins, which are the jugular veins, they start to expand and fill up because of that back pressure, because they can't drain into the heart, the pressure's coming back up towards the head. And sometimes they can get pretty thick, and they're pretty unmistakable once you see them. The other thing that you would discover is there's going to be unequal chest rise, because the one side that's affected, obviously that lung's compressed, that chest isn't going to rise. You may get minimal rise on the other side because of what I just told you with the heart impairing that lung function as well. And then also what you'll pick up on is diminished breath sounds. There's no air movement because the lung's compressed, so you won't hear anything. And you may hear some air movement on the good side or minimal depending on how much pressure is actually built up within the chest itself. So the key is, what do we do about this? And at the EMT level, ventilation is going to be a premium here. Put it in an adjunct. If you're allowed to, some type of alternative airway like a King or an iGel or something along those lines, and ventilate your patient. When it gets to the point where there's a tension that's developed, your compliance, which is the resistance that you have to ventilate against, the compliance is going to be pretty bad. You may have a very hard time ventilating this patient. Your paramedic that's with you, what they will do is take out a needle and hopefully be able to put it deep enough into the chest that allows that air to start to escape. Once that air can go somewhere other than staying in the chest, that pressure should start to be relieved. And with your ventilations, hopefully what happens is that it starts to allow that affected lung to re-expand. And also, as that happens and that air escapes, allows that heart to shift back over and take pressure off the unaffected lung and allow for more and more perfusion to go through there, and better oxygen levels start to build up in the bloodstream, and then hopefully get back to the left heart and get out to the body. Now, that's with a closed injury. If there is an open injury, the first thing that you'll want to do if you see anything like that in the chest is put your gloved hand on it. We don't want any more air getting in there. The next thing is seal it down. Now, your protocols may tell you one thing versus another. Some will say tape it down on 3 sides. Some say tape it down on 4 sides. Both are adequate. The reason for the 3 sides is that if there were enough pressure to build up, that 4th side should be allowed to kind of flap up, if you will, and allow some of that air to escape out the hole. But in the meantime, still doesn't let air get in the chest. The problem with that is that most of your trauma patients aren't nice and clean and sterile. So they're going to be sweaty, they're going to be bloody, they're going to be dirty, and that 4th side tends to get gummed up, if you will, and stuck to the chest. So what you'll need to do is obviously lift up that 3rd or 4th side and make sure that every once in a while you try to let the air out. So with good ventilation, obviously closing any holes that are in that chest, and with that medic, if you're working with a medic, getting that needle in the chest to let the air out, those are the best things you can do to discover that tension pneumothorax and fix it.